Good evening, everyone. Thank you for joining us for tonight's presentation on sacroiliac joint dysfunction. With us tonight, we have Dr. John Eager, and he's going to be giving his presentation. So, Dr. Eager, whenever you are ready.
All right. Thank you, Savannah. Welcome, everybody. Looks like we've got 22 viewers, if I'm not mistaken. Tonight's discussion, so with our new Spine Institute, we're going to be hosting periodic webinars discussing different diagnoses, treatment therein. Tonight, we've selected the topic of sacroiliac joint dysfunction, understanding the sacroiliac joint, going through the diagnosis, different treatment options, both non-surgical and surgical. Before we get started, just a little background about myself. So I am relatively new to OrthoSouth, came here on the latter half of 2024. I am a board certified orthopedic spine surgeon, did medical school residency training in Houston, Texas, went off to Atlanta to complete a fellowship at Emory in musculoskeletal oncology, and came back to Houston to complete my combined neurosurgical and orthopedic spine surgery fellowship. Practiced for a few years in Houston, and then here I am. I'm proud to be part of OrthoSouth. So again, this is just an overview of tonight's discussion. We'll go through all of this and have some time to answer a few questions if there are any at the end of tonight's episode. So we're going to be reviewing the anatomy of the sacroiliac joint. We'll be referring it to more commonly as the SI joint. The characteristics of SI joint dysfunction, how it presents, which is variable as we'll go through, the diagnosis of sacroiliac joint dysfunction or sacroiliitis, different treatment alternatives. So again, non-surgical and surgical options. And then at the end, a summary and questions. So lower back pain is second leading cause of office visits in this country. Here are some statistics and the associated costs. So as a spine surgeon and our non-surgical physiatrists, we see majority low back pain complaints, and so do majority of primary care visits. A basic overview of spinal anatomy. So we're working ourselves all the way down into the pelvic region. So the sacrum is the bone at the bottom of this cartoon depiction, colored in blue, that adjoins the pelvis, or the ilium specifically on either side, making up the sacroiliac joint. Where is the SI joint? So this is not a very good illustration. Here we go. So again, detailing the junction of the sacrum and the ilium. The sacroiliac joint is on both sides. Certainly, it's a very complex anatomy. The joint surface is not a mobile joint surface like a hip, a knee, elbow. It has an irregular contour. You have very strong ligamentous attachments in the front and back, and you also have muscular stabilization. On the far right, there's mention of complex innervation, and this is true. There's been multiple studies regarding the innervation of the sacroiliac joint, multiple nerves, and this leads to its variable presentation. And we'll go over that some later on. So this is a slide detailing the prevalence of SI joint pain based on multiple studies dating back to the 1980s, with somewhere around 15 to 30% attributing it to a component of chronic low back pain. Interestingly, on the right, so symptomatic post-lumbar fusion. I see this more often than not. So patient has, as a surgeon, it's important that we discuss the prevalence of adjacent segment deterioration after a fusion. And this can occur anywhere in the spinal column, above or below a fusion construct. And certainly in lower lumbar fusions, the SI joint becomes adjacent and can oftentimes become symptomatic. So here are some common causes of SI joint dysfunction that we see. Not all causes, but certainly trauma, such as a car injury, a fall. I've heard patients stepping off the curb, so it doesn't have to be a high energy impact. Heavy lifting, repetitive micro trauma, The last one's interesting, pregnancy or childbirth. So there's quite a predilection of female patients that present with SI pain as a potential primary pain generator, thought to be due to the hormonal changes. And then certainly degenerative conditions such as arthritis, or as we previously mentioned, after a lumbar fusion with adjacent segment deterioration. So presentation of SI joint pain. Again, it is variable. Classically, patients will localize it at the top of the buttocks, either the right or left side. It can present as lower back pain. It can present midline, sciatica-like symptoms. By that, we mean radiating pain. So pain can radiate. Most commonly, I see it posteriorly, so down the buttock, down the posterior thigh. However, it can present with radiation to the groin or anteriorly as well, and it can radiate all the way down to the foot. Patients will also describe sensations of numbness, tingling, weakness, burning sensations. They'll complain of buttock pain, pelvis pain, even lower abdominal pain can present from SI joint dysfunction. And then this is a common description that we hear in clinic, a feeling of instability such as buckling where my leg feels like it's going to give way. Again, similar symptoms. This is a type of condition that can severely limit a patient's ability to function. We hear about inability to stand for long periods of time, difficulty walking, stiffness is a common complaint, disturbed sleeping patterns, so tossing, turning, I'm unable to lie on my side at night, waking up, having to constantly twist, turn, use pillows in between their legs. Pain going from a sitting to standing position. So commonly I'll ask patients, does the pain exacerbate when you're rising from a chair? How about climbing stairs? So diagnosing the SI joint, this mentions it's being rediscovered. Interestingly, in my training, not all surgeons were of the belief that the SI was a primary pain generator, and it often went overlooked or ignored. I think there's a lot of misdiagnoses or underdiagnosed SI joint conditions in the low back pain population. Not usually part of the low back pelvis hip workup, which is true. I think SI joint dysfunction is certainly a diagnosis of exclusion. And, most commonly people will present complaining of low back pain. From a spine surgeon's perspective, we're looking at the lumbar spine. From a hip arthroplasty perspective, you're working up and ruling out any hip pathology. But the referral patterns are similar for lumbar spine and hip pathology. SI joint pain is necessarily, ruled out or ruled in after you evaluate the lumbar spine and hip for any additional conditions. Physicians are not trained to look for it. I would agree, not all. I think that may be changing, certainly in the latter half of my training. I think it was more, at least people put more attention to looking into it as a potential diagnosis. I think oftentimes, someone can present and have some radiographic findings that kind of takes the attention away from a potential SI diagnosis. However, that's the importance of taking a careful history and conducting a thorough physical examination. SI joint pain diagnostic criteria. So the pain is present in the region of the SI joint. Commonly, patients will present just like this picture on the left of the slide, where they're localizing it with their finger, a positive Fortin's finger test. They'll point right there over the PSIS, which is the protuberance in the back of the spine, at the junction, again, of the sacrum and the ilium. Diagnostic testing. So here we have the importance of performing a careful physical examination. Provocative testing reproduces patient's pain. So at least 3 provocative tests that reproduce the patient's usual pain tends to guide me and lead me to think, at least bring the SI joint in the differential of the diagnostic plan. So here you have someone performing a compression test while the patient's in the lateral decubitus position. And then more invasively, SI joint injections. So we will send patients, we're ruling out lumbar spine hip pathology. If I am, considering the SI joint as a potential primary pain generator, I will send my patients to our physiatrists for a diagnostic SI joint injections in the hopes that it will relieve the majority of their usual pain. Now, pain can be, multifactorial. They can have lumbar spine issues, hip issues, and SI joint issues. So it's really important to isolate a patient's primary pain generator. And the injections are useful. For me, injections are useful, at least from the surgeon's perspective, as potentially diagnostic. So I always tell my patients, if I send you for an injection, I'd like to see you back in at least 1 to 2 weeks. If during that time period, the injection relieves the majority of your usual discomfort for any period of time, and I don't care if it's for a few hours or a few days, that leads me to believe that the SI joint is indeed a primary pain generator. On the flip side of that, hopefully, a corticosteroid-based injection combined with, other non-surgical approaches can be more therapeutic, meaning long-lasting relief and the potential to avoid surgery. So here, localization of pain. So again, we have this picture, this positive Fortin's finger pointing just above the buttock, lateral to midline. This is the most common presentation for me. Again, we mentioned earlier that the presentation is, again, variable. Patients will have pain midline. They'll have pain radiating to their coccyx or their tailbone, sometimes in their groin, which can make this diagnosis of this condition difficult at times. So again, to provocative testing, here's some examples of what we do in clinic to evaluate the SI joint as a potential pain generator. You have a distraction test where you're applying force in a patient's supine position over the ASIS, thigh thrust, or posterior thrust. Faber is another common figure of 4 position to load that sacroiliac joint. Compression test, again, on the lateral decubitus position. And at the bottom of the slide, again, 3 of 5 provides a pretty powerful diagnostic power. It's not definitive, certainly, but it certainly is suggestive of SI joint pain. Most commonly in my clinic, we're performing posterior thrust, Faber compression testing. If there's any equivocal exam findings, we may add on 1 or 2 more of these. SI joint injection, again, we're ruling in or out the SI joint as the source of pain. Again, I send my patients to physiatry. I do not perform injections myself, but it is a procedure that's performed under imaging guidance. Again, due to the anatomy of this joint, it's irregular, it's in a difficult location, so you want to have appropriate imaging to establish your position, make sure that you are within the sacroiliac joint, confirming this is important, confirming the needle is in the joint with a small amount of dye or contrast. So they'll inject that, that dye within the joint under the x-ray and then have that direct visual confirmation that they're in the right place, after which a local anesthetic is administered. So the diagnostic SI joint injection, pain relief and functional improvement. So greater than 50% pain reduction can indicate the SI joint may be a pain generator. Typically, I like to see majority relief, greater than 50%, greater than 60, 75%, ideally. Again, pain is subjective. Less than 50% indicates that you may have SI joint pain, but other pain sources should be considered. And again, back to my earlier point on establishing a patient's primary pain generator, people can have multiple issues going on. It's important to hone in on their primary source of pain to have a more targeted treatment strategy. And again, ideally, from a therapy, there's a diagnostic component to these injections. And, I mentioned the flip side of the therapeutic, having more functional improvement. I've had patients, I was asking specifically about their percentage of pain relief, and they replied with, hey, I'm able to walk longer and longer distances after my injection. So that points to the functional improvement following these injections. Non-surgical treatments. I think it's important, me as a surgeon, I try to treat my patients non-operatively if possible. I think surgery for this type of condition should be considered a last resort. There are oral pain medications. I think there's use to that in the short term. I'm not a proponent of long-term pain medication for any of my patients. Some patients get some relief, temporarily or longer term with chiropractic treatment and physical therapy. On the bottom left of your screen, there's a sacroiliac belt. I've had few patients try this. And again, it's typically a temporary relief when they're up and about, not really a long-term type of solution. The steroid injections we've already been through. Radiofrequency ablation, that's another more invasive treatment that our physiatrists can perform. So if a patient has had positive response, and I don't know if we have any of our physiatrists online with us today, maybe they can speak on this in a little more depth or comment, but the ablation is another treatment modality that we'll use short of a surgery, at least, in the hopes that we can provide the patient longer term therapeutic benefits. So pictured previously, the SI belt will wrap around the pelvis, the ilium specifically, in an effort to provide compression of the SI joint. Treatment goals here, again, external compression, an attempt to stabilize the joint and decrease pain. Now this joint, again, as we mentioned earlier, is not a very mobile joint. We're talking about 2 to 3 degrees motion, again, with certain hormonal changes. Sometimes you get increased laxity that that mobility may increase, but it's not a terribly mobile joint by any means. And at the bottom, yes, it's often uncomfortable and poorly tolerated. I've heard that quite a few times. Physical therapy, excuse me, is certainly a useful modality with instruction on proper body mechanics, performing ADLs, gait balance training. Posture is also an important part of physical therapy with good motor control of the core. Our therapists here at OrthoSouth and elsewhere, I'm sure, will also perform additional therapeutic modalities such as soft tissue mobilization, manual therapy, and cardiovascular conditioning can also play a role. So therapeutic SI joint injections. There's a therapeutic SI joint injection, again, in the hopes that we can have treating the symptoms in a longer term manner. It's different from a diagnostic injection, which would just use a local anesthetic, typically with several hours window of effect. But again, it's performed under imaging guidance. We've already talked about confirming the importance of confirming that you're actually in that joint, as opposed to just spraying the corticosteroid around the soft tissues, which is completely non-diagnostic. So very important that we inject contrast into that joint, confirm you're in it, and then follow that up with the medicine. But again, this does not stabilize the joint. This is certainly treating the symptoms only. And here, the radiofrequency ablation, colloquially, it's burning the small nerves that provide sensation to the SI joint. And the small nerves that provide sensation are variable. There's some coming from the lumbar plexus, the sacral plexus. This modality is temporary, much like an injection, and the nerves can regenerate over a period of time. Again, this is treating the symptoms of SI joint related pain and not stabilizing the joint in any manner. Onto the surgical side of treatment. So here we have a specific vendor's implant system. So I'm not affiliated with iFuse or SI-Bone in any manner. They're not paying me. I don't receive any royalties. But I have, over the last 3 to 4 years, elected and have preference for this system. So this is a manner in which we stabilize the SI joint, which we're unable to do with injections. Minimally invasive. From that standpoint, it's through a small incision. These are typically performed outpatient. I don't think I've ever had a patient stay overnight. It's a very short procedure overall in comparison to some of the other procedures that I perform. Less than 1 hour for sure for a unilateral SI fusion. Is this a video here? I don't know if this is going to play. Oh, there we go. Well, I'm not getting it to play here. So this goes through kind of the procedure of the SI fusion using this particular implant system. And for me, let's see if we can go back. There we go. So that was instructive. Yeah, so this is a type of implant system that uses, as you can see, these are titanium porous triangular implants. And we attempt to, assuming there's no dysmorphia within the sacrum, try to implant at least 3 of these titanium dowels across the SI joint in the hope that we provide immediate stabilization, their triangular shape, prevent that minor rotation of the SI joint. We go through the cartilaginous surface at the sacrum and ilium to denude it. During the process of broaching these implants across, we are harvesting bone. You can see the fenestrations in the bottom right of these implants to allow bony ingrowth. And again, their porous structure helps facilitate that as well. And here we have a little cartoon depiction of just the placement of these. So this is done under X-ray guidance through a very small incision over the lateral buttock in line with the sacral anatomy. So we place a guide pin in here. Again, we're positioning it in the AP and lateral projections to make sure that we're in the appropriate place. The implant insertion, after we place our guide pin across, confirm in all planes with X-ray that we're in the appropriate position. I then go in with a broach, okay, to create an opening and a path for my final implant. Once that is created and we've made it across the sacroiliac joint, again, confirmed under X-ray, at that point, I will obtain a measurement to select the appropriately sized implant. And then I will pass that through the hole we created with our broach and impact that into place and seat it like you see here. You want the first implant superior above the S1 foramen. The second implant I try to position just lateral to the S1 foramen. And the third caudalmost implant is seated between the S1 and S2 foramen. Here's a little description. Again, we're talking about the unique design of this particular implant. There's numerous vendors out there. Again, this is the one that I prefer at the moment. But the triangular design, again, is meant to minimize rotation, micromotion. It has a large surface area designed to stabilize and fuse the SI joint, which is heavily loaded. Again, it's in the posterior aspect of the pelvis. It's the majority of the weight bearing through the pelvis as opposed to the front. And again, the porous surface, titanium surface, allows for the bony ingrowth and on-growth. So these next couple slides will go through some of the trials with iFuse specifically. There have been numerous procedures performed to date, decade plus of clinical experience, numerous publications that point to this as a worthy modality in the definitive management of SI joint pain unrelieved with non-operative treatment. So some of the results, I know these are busy slides. I won't belabor these too much, but multiple issues showing the pain, visual analog scale pain before and after treatment with the SI bone iFuse system. 91% patient satisfaction on average, again, through multi-center prospective and randomized controlled trials. Here we have a 2-year results of the iFuse systems comparing non-surgical management and SI fusion. So the Oswestry Disability Index is commonly used in the spine realm as a measurement of patients' pain and disability. So we see a pretty significant drop in the months following an SI fusion. And again, on the right, the visual analog scale, how patients are rating their pain during this recovery process over a 2-year period. So we see the non-surgical management in the blue at the top with minimal changes in the ODI or the VAS pain scale. Again, another study, 5 years, sustained results. Again, you can see the SI joint pain as rated by the patient, and the ODI, mean 54 improvement in the VAS visual analog scale, and 26-point improvement in the Oswestry Disability Index. And for those, you can see how this, the Oswestry Disability Index, if you're over 40 and above, you're pretty disabled with pain at that point. When you're coming down to 20 and 40, that's marked improvement, but up to 60, initially is where we're seeing patients, they're in severe pain. Their life, their quality of life, their functionality is severely diminished. Here is just a slide for those interested, a list of published studies if you wanted to go to the SI Bone website. Again, I don't have any affiliation directly with this company, but it is an implant I use and employ to this day. Again, this implant is something that we use when patients have failed non-operative treatment. So they've gone through the therapy, we've diagnosed it, or we at least feel that it is a potential diagnosis through our history, through our exam. We've sent them to therapy. They've tried the injections. For me, I like at least 2 diagnostic injections pointing to at least majority relief of the usual pain for any period of time. It's a method to treat SI joint dysfunction, sacroiliitis. It can be degenerative, again, trauma, typically microtrauma or hormonal changes related to childbirth or menopause. This method is used to augment immobilization and stabilization of a joint that truthfully is very minimally mobile. Some people hear a fusion and they get worried about, will I be able to move the way I used to? And, it's your experience after this type of procedure, this fusion procedure, is negligible from a range of motion standpoint. So in summary, if you have lower back pain, ask your physician if he has considered the SI joint as a possible cause of your low back pain. Not all physicians are tuned in to look at this or diagnose this. And, I think if other potential pain generators, the lumbar spine, the hips, have been ruled out, I think it is a worthwhile consideration. And if the SI joint pain is found to be a source of pain, there are numerous non-surgical treatment options. We just went through all the, the surgical methods. But certainly patients can and do get better with non-operative treatment. And if non-surgical treatment is not successful, that's when I consider indicating my patients for this procedure. So they have failed everything. I have high confidence that their diagnosis is SI joint dysfunction. And they've had a positive response with the injections. It gives me high confidence as a surgeon that we can make them better with an SI joint fusion. So what is your next step? Come and see me. Here's some contact information. You can see me or one of our other providers, certainly. And again, our physiatrists are also available to help with the injections or radiofrequency ablations if those are indicated. Here are some of our references that we used in the making of this slide. And that's it. I'll take some time for some questions if we have any. Savannah, do we have a comment section over here? Okay, from Carolyn Lusk, does laser treatment help? I don't know what that means, laser treatment. Is that a reference to radiofrequency ablation? I'm not sure. We do not use lasers as part of a treatment or workup strategy for this particular diagnosis. But radiofrequency ablations is used to treat the symptomatic component of SI joint dysfunction by essentially zapping those sensory nerves. Gloria Dobbs asks, are there instances when injury to the SI joint has to heal with time, even if an injection is received? Yeah, I think there's an opportunity. I mean, the human body is incredible, and it makes my job as a surgeon possible in its capacity to heal. So I think, and that's where the non-operative treatment of this and other spinal conditions are important. So we try to treat our patients non-operatively if we can. I think there's an opportunity for healing to occur if there is some micro trauma, and in that process, that's where therapy, bracing, or injections can be beneficial. Again, short-term course of medications. For me, I use typically anti-inflammatories. A short dose of a Medrol dose pack. I'm not a proponent of long-term steroid use. Non-steroidal anti-inflammatories, are okay in the short term again, but there's a risk profile with everything, medications included. Renee Hobbs asks, after you have an SI fusion, what is the time you are fully healed? That's a good question. So I tell my patients the first couple of weeks after surgery, they're probably going to hate me. We have to go through the buttocks, and many times they're very sore. But I get my patients up weight bearing immediately. They may need the assistance of crutches or a walker initially, but I want to get them on their feet. Again, I use the 3 titanium dowel method, to provide immediate stability. But in reality, a fusion, it can take several months to a year to fully incorporate that bone and fuse across that joint. So fully healed, I've had patients come back at the 6-week mark, doing incredibly well with 0 pain. And some patients are coming back, 3 months, and until they've had a really significant response. But, I always counsel my patients it can take up to a full year before you kind of reach your plateau, or what I would consider to be a plateau in their healing process. Carolyn Lusk, I need to make an appointment with you. Please do.
All right, Dr. Eager, you ready for a few more questions?
Sure, go ahead.
How do different comorbidities such as osteoporosis or rheumatoid arthritis affect treatment choices or outcomes for SI joint dysfunction?
Yeah, those are big ones. Osteoporosis, it significantly affects the quality of the bone, what we're able to achieve with any fusion, increased risk of fractures, implant loosening. For me, as a surgeon, if I'm considering indicating someone for a fusion here or elsewhere, and there is some concern either with age or with what I perceive to be a bone quality issue on their imaging, I send them, for DEXA scan to assess the bone density and to see if there's any role for medical management to optimize their bone quality prior to indicating them for a fusion type of surgery. You mentioned rheumatoid arthritis. With this and other surgeries, rheumatoid arthritis there's shown to be increased complications with wound healing, infections. Certainly, if they're on biologics or immunomodulators that can affect their ability to heal, that can adversely impact it. But again, that's part of the history taking and the workup of a patient, making sure that you understand the whole picture. If they're on certain medications that may adversely affect their ability to heal, we have that conversation, coordinate with their rheumatologist, window to either come off those medications or restart those medications post-operatively.
All right, and what role do lifestyle factors play in SI joint healing or pain?
Well, I think we talked about some of the causes.
Yep.
Repetitive micro trauma can lead to this. Lifestyle, I think there's a genetic component as well, to have a chronic or accelerated degenerative process, and certain lifestyle choices can adversely affect, number one, your ability to heal, the quality of your tissue, your bone, smoking, alcohol use. These are all things that we look for and ask our patients about. But I think, and we also mentioned, particularly in females, the hormonal changes, particularly around childbirth or menopause, can come into play as well and make this a more symptomatic issue.
Okay, and I know that kind of addresses Miss Melanie's question a little bit, but do your recommendations vary by age of the patient?
My recommendations as far as what? So Melanie, my recommendation would be, I would still go through all the non-operative treatment options with you, regardless of your age. Again, I try to treat my patients non-operatively. If they get better without surgery, great. But I think at an advanced stage, I'm certainly more tuned in or concerned about making sure their bone quality is optimized. I think if we're looking at a 43-year-old male versus a 76-year-old thin woman, there's going to be some bone density changes there that may affect my recommendations, or certainly the way that I approach working it up or indicating a patient for treatment.
All right, and I think we've got time for one or two more questions.
Sure.
How does the surgical learning curve for minimally invasive SI joint fusion affect complication rates or patient outcomes?
Yeah, I think there's absolutely a learning curve. This is what we would deem to be a minimally invasive through a small incision outpatient type procedure, as opposed to a large open procedure. But the pelvic anatomy is complicated, and patient body habitus can sometimes impact our ability to see appropriately. So number one, when I have a patient on the table, it's very important that we get their positioning perfect in respect with our imaging planes. So I need to have perfect orthogonal or perpendicular planes when I'm viewing and imaging their pelvis, to ensure that I'm guiding these instruments, these sharp instruments, in the appropriate direction to apply good fixation and avoid a neurologic injury, which is absolutely a risk of spinal surgery. But there is a learning curve. There is, you want to have someone that's well trained and performs these procedures, because it's not risk free. I say that's an outpatient procedure, come and go home the same day, but that doesn't mitigate any of the risks, and I'm certainly mindful of that.
And last question, what specific clinical signs might indicate a rare complication such as infection or nerve damage following an SI joint fusion?
Yeah. So when we're operating at the SI joint, you're in very close proximity to the sacral nerves. So if patient starts developing new onset neurologic dysfunction, bowel bladder dysfunction, increased pain that they did not have prior to the surgery, that would certainly cause me concern and lead me to want to investigate, either with postoperative CT or some advanced imaging to ensure that, number one, that our implants are positioned correctly and that there's no neurologic complication. If the patient has continued pain after surgery, after several months, my question would be, did this thing actually fuse? Again, I would probably look for loosening of the implants with the CT, and to assess the actual fusion across that SI joint. And again, that's where the whole workup comes. We have patients with osteoporosis. I want to try and augment that bone quality with medical management before we proceed with the surgery to avoid those complications.
Thank you, Dr. Eager. And okay, we just got two more questions and then we'll be done. Ms. Renee wants to know, where do you do the surgeries?
Surgeries here in Memphis, I'm performing the surgeries, mostly St. Francis hospitals, but in our surgery center in Germantown is where I've been performing these of late. So it's an outpatient procedure. I think we've had good results and good experience at our ambulatory surgery center there in Germantown. I think it's an appropriate case for that facility. For any reason, should a patient have, a myriad of medical comorbidities that would have me concerned and maybe want me to have them in closer proximity to higher level of care, should any need arise with a medical issue, I would perform the surgery at one of our hospitals locally.
All right, and last question of the evening. How do you go in when doing this procedure? From the side of the hip?
Well, yeah, I didn't. Let me see if I can go back to one of our slides. So I go in from the side. So on slide number 2, so patient is lying prone or face down on the table, and I make an incision, about 3 centimeters over the buttock. Okay, just corresponding to the contour of that sacrum, the proximal sacrum. So it's going through the side, above your hip joint, but through the gluteus muscle fibers down to the ilium.
All righty. Well, thank you, Dr. Eager, and thank you everyone for joining us tonight. This
My
webinar
pleasure.
is available as a recording on all of our social media platforms. And finish. Thank you again, and everyone have a good evening.
All right, thank you, Savannah. Thanks everybody for joining us.